Hi everyone. We'll just give it a few more minutes for some people to arrive and then we'll get started. Hi everyone. Now that some more people have had a chance to arrive, we'll get started. So welcome to this Thursday's teaching session. My name's Katie. I'm one of the F1s. Oh, hang on, let me turn my camera on. Hi. I'm one of the F1s working in Bristol at the moment. And this session tonight will be about haematology. So just a bit, Thursday 15, as you probably already know since you're here, are like a free online medical education platform that run weekly sessions aimed at mainly final years, but and fourth and third years as well. Just running through 15 high yield MCQs, and then we go through all the answers. So can you all see my slides? I think I've enabled the chat for this one, so you guys can talk.
Yes, we can see the slides.
Oh, fab, great. So yeah, haematology tonight. So how we'll start is we'll go through the 15 questions like it's like a mock exam. So I'll give you like a minute per question if the stem's quite long, but like maybe 45 seconds, 30 seconds if it's a really short question. And then we'll go through all the answers. So if everyone's got a pen and paper just to note down their answers as they go, and then when we run through them and the answers, we'll do like a little poll on the screen and you'll have the opportunity to put what you put as the answer, and then we'll talk through it. So if we just go straight into it, here is your first question, so you have 1 minute. Okay, next question. Question 3. Question 4. Give you 30 seconds for this one. Hopefully that was enough time. So question 5. Question 6. Question 7. Question 8. Question 9. Question 10. Question 11. Question 13. Question 14. Last question, question 15. Okay, guys, well done. That's the end of the questions. So we'll go on to the answers now, if you're ready. So just going back to the first question, I'll try and start a poll and you guys can say what you put down. So that should have come up on your screen now. So this question was about a young woman who came in with fatigue, abdominal pain, diarrhea, and weight loss. She's got some signs of anemia, then her blood tests confirm that she's got what looks like a microcytic anemia and a bit of an inflammatory response. So I can see from, let me just share your answers. I can see from your answers, most of you have been split between celiac and IBD, which is kind of what I expected. So the reason, hang on, let me go into the answer. So the things that kind of suggest it's more IBD was the correct answer, is that she's young, she's got abdo pain, diarrhea, she's lost weight, stopped having periods. She's got like abdominal tenderness. The reason it's IBD over celiac is because she's had this isolated episode of uveitis. So that's more associated with the IBD. So if we go through them all, so A, she reports she's got a good appetite. She doesn't, and this wouldn't account for her diarrhea and weight loss and the elevated CRP. B, uveitis would be more suggestive of IBD, celiac more likely to present in childhood or in the over 40s. GI bleeding wouldn't usually cause weight loss, would generally present more acutely. Malignancy, so like a GI malignancy, I guess, would be really uncommon in someone of this age group. So IBD is quite common in people in their early 20s, abdo pain, diarrhea, associated uveitis and that elevated CRP, all would point you towards E as being the correct answer. So I haven't particularly, in the explanation, I haven't particularly got into detail loads on like the signs and symptoms of anemia. I just don't think it's particularly like high yield for your exams. But I don't know if people want to put in the chat a couple of things that you might see in anemia, like classical impaired oxygen carrying capacity type symptoms. Can you guys write in that chat? Fatigue, yeah, that's one. That's a good one. Other stuff is just like exertional chest pain, palpitations, intermittent claudication, shortness of breath, headache, dizzy, tired, all of those kind of things. And then all the signs are all the stuff that you learn for your like third year GI exam. So like pallor, they might have a murmur, those nail changes, hair loss and stuff like that. So I think it's better if we focus really more here on the different causes. So you can really split it into kind of like reduced red cell production. So that might be because you have insufficient erythropoietin, which is the hormone that drives red blood cell production. And you would have insufficient erythropoietin if you had low iron. And there are lots of reasons why you might have low iron. It might be hormonal, so you might have low EPO. You have low EPO when you've got like CKD or hypothyroid. It might be insufficient because you've got bone marrow suppression, maybe you've got like a hematological cancer, bone marrow infiltration. Certain medications can suppress your bone marrow as well, so that can lead to reduced red cell production. And then you can have ineffective red cell production, so you've got an abnormal process of creating red blood cells. And that would be if you had like megaloblastic anemias, so the B12 folate deficiencies, thalassemia, so you've got abnormal hemoglobin, myelodysplastic syndrome or sideroblastic anemia. So sideroblastic anemia is basically where the red cells can't form the molecule heme, and then it leads to deposits of iron in the mitochondria, which forms a ring around the nucleus that they call a sideroblast. It's a bit rogue. It can be congenital or acquired, but we won't talk about it any more than you just need to know that it's a cause of anemia. And then the other side of anemia can be like increased red blood cells destruction or loss, i.e. you're bleeding. So red blood cell destruction is hemolysis, so the destruction of red cells. And that can be, we'll go more into this later as well, but that can be because you've got like red cell membrane abnormalities, metabolic abnormalities, or problems with your hemoglobin. And those things would lead to you having anemia. So anemia is also classified by what the cells look like. So if they're small cells, so then they're microcytic, and that can be iron deficiency, thalassemia, hemoglobin problems. The sideroblastic anemia, lead poisoning, or just anemia of chronic disease can be microcytic. Normocytic, so it's going to be stuff like blood loss, CKD, myeloma, pregnancy. And then macrocytic can be megaloblastic or non-megaloblastic. So megaloblasts are essentially just like immature red cells, and they just have a big nucleus and not very much cytoplasm. And the megaloblastic macrocytic anemias are B12 and folate deficiencies. And they're needed to make DNA. And so that's why when you have abnormal DNA synthesis, you have impaired cell maturation. So then you get a buildup of these immature red cells, which is why they're megaloblastic anemias. And then the non-megaloblastic macrocytic anemias are stuff you'll see in like chronic alcohol users, people with liver disease, hemolytic anemias, hypothyroid, certain medications, and myelodysplasia. So essentially, when you've got like a question about anemia and they're showing you a set of blood results, it's important to look at the MCV because they're kind of narrowing down your differentials for you in the question. So just remembering a table like this can be really helpful. There's a couple of pictures of the classic anemia signs. So this one's that spoon-shaped nail, so the koilonychia, and there's some angular stomatitis around the mouth. So iron deficiency anemia is important because it's really, really common. They can ask you a lot of questions about it because there's lots of causes of iron deficiency. So iron is needed to make your hemoglobin. It's mainly absorbed in your duodenum and your jejunum. So if you don't have them, then you're more likely to be iron deficient. Your stomach being really acidic keeps iron in like Fe2+, which makes it soluble. So if your stomach is less acidic, then the iron will be held in Fe3+, which is insoluble. So then you can't absorb it as well. So when people are on things like PPIs, which reduce the level of acidity in the stomach, that can predispose them to iron deficiency anemia as well. So yeah, you can also split iron deficiency into the same way that we split the anemia. Reduced uptake, so if you're not eating it, if you're not absorbing it, or if you haven't got vitamin C, if you're losing it more, so if you're bleeding, if you're on NSAIDs, or you've got like inflammation in your esophagus, or you've got a cancer, or you've got heavy periods. And then if you're using it more, like if you're pregnant or lactating, that will make you iron deficient. So looking into it further, you do blood tests, so the classic FBC, hematinic iron studies. You can also do anti-TTG, looking for stuff like celiac, or do scopes, or do a rectal examination looking for melena. If they were over 50, you'd always consider a 2-week weight cancer referral for scopes top and bottom to look for any cancers or source of bleeding, and you'll treat the cause. So if you're trying to correct an anemia, then you'd go for ferrous sulfate 200 milligrams TDS. But if other things that you can think about is like, are we addressing their diet properly? Have we replaced their vitamin C? Are we managing their heavy periods? And if we're doing all of that and it's still not getting on top of their anemia and their hemoglobin sort of less than 70, then we'd consider giving someone a blood transfusion. Or if they were having ACS, then the threshold's a bit higher, so 80. Yeah. So were there any good questions about that? That's a feedback link. Okay, so question 2, let me start the poll for that one. So this question was about an anemia again, so but this man's got a macrocytic anemia. He's clearly from the question got a low B12. He's also got a low folate. He's got a slightly raised bilirubin and a raised LDH. He's presenting with some peripheral neuropathy type symptoms, but he doesn't drink lots of alcohol. He eats a good diet. And his past medical history is significant for type 1 diabetes. So just from the quick poll, most of you have gone for B, which is the correct answer. Well done. So blood's for intrinsic factor antibodies. So you've all got that he's got a B12 deficiency. The other one that a couple of you went for was A, which was prescribe the folic acid replacement first before you could correct the B12. So that's not correct. It's the other way around, and you've got to get that in your head. So you always have to replace the B12 before you have to replace the B12 first every time, because if you correct a folate deficiency, then you might mask symptoms of a B12 deficiency. B is correct. So we're looking for like a pernicious anemia as a cause of his B12 deficiency. So liver ultrasound for C, that wouldn't be correct. People might go down that track because of the raised bilirubin, but that can happen because of increased cell turnover, and hemolysis can release heme, which is then broken down to bilirubin. So that pushes up your billy, but it's nothing to do with your liver. An upper GI endoscopy, you might consider if the intrinsic factor antibodies came back as positive, because you might want to be looking for like any gastritis in the stomach, but we don't know right now that's quite an invasive thing to do without knowing that he's got pernicious anemia. And then the last one is colonoscopy, and there isn't really an indication for that in the question. So B12 deficiency, as we've said, B12 folate are needed in DNA synthesis. A deficiency leads to impaired cell maturation, so you get lots of megaloblasts, which are immature red cells. B12 is absorbed in a particular way. So your parietal cells in your stomach make something called intrinsic factor, and that binds to B12. And the B12 intrinsic factor complex is then absorbed in the ileum. So if you have something called pernicious anemia, which we'll go on to talk about, then your intrinsic factor is being like destroyed by your own antibodies. So you can't absorb the B12. You might not also absorb it in IBD or gastritis. If you've had an ileectomy or a gastrectomy, then you're not going to make intrinsic factor, or you're not going to absorb it in the ileum. If you're on PPIs, that'll affect it. Poor diet, alcoholism, then that will affect your B12 absorption. So you present with things like peripheral neuropathy or subacute combined degeneration of the cord, which always sounds really scary. It's basically like your dorsal and your lateral columns in your spinal cord demyelinate. So you get progressive weakness, ataxia, and paresthesia, so like funny sensations that can progress to kind of total spasticity and paraplegia. It presents quite insidiously, but this is the thing that we don't want to miss with people with B12 deficiency. So that's always why you always replace the B12 first. So if you replace the folate and you keep letting the B12 get lower and lower, it can precipitate those neurological complications. So to treat it, you just prescribe like IM, cobalamin, and you can give it a few times a week for 2 weeks, and then every 3 months for life. And you can give oral folate to replace that as well. So pernicious anemia is quite common in Northern Europeans. Lack of intrinsic factor, as I said, so they can be anti-parietal cell antibodies, so stopping the production of intrinsic factor, or they can just be anti-intrinsic factor antibodies. It's associated with other autoimmune conditions, so like our man had type 1 diabetes, predisposes him to stuff like pernicious anemia. It increases your risk of malignancy as well, so particularly gastric malignancy, which is why if you've got someone with confirmed pernicious anemia, you'd think about doing an upper endoscopy. Okay, so question 3, just get the poll up. So this question was about a 46-year-old lady presenting with worsening fatigue, weakness, and abdominal pain. So she's jaundiced, she's got splenomegaly, she's got like quite a significant anemia, and her Coombs test has come back positive. So which of the following is most strongly associated with her likely diagnosis? I think this is quite a hard question. So you kind of all split again between B and D. Well done. So those of you that said B, that's the right answer. So the answer is lupus. So she's come in with jaundice and her Coombs test is positive. So the diagnosis that we're worrying about in this lady is, giving it away, hemolytic anemia. So some drugs can precipitate hemolytic anemia, which is why some people might have put A, treatment with metronidazole, but it's generally like penicillins and cephalosporins that can cause hemolytic anemia, so that's wrong. B is right, lupus is quite strongly associated with hemolytic anemia, autoimmune hemolytic anemia. Colorectal cancer, so autoimmune hemolytic anemia can be linked to some cancers, but it's uncommon. It's more likely to be hematological cancers that it's related to. Liver cirrhosis and TB are rarely associated with autoimmune hemolytic anemia, but they can be. But lupus is obviously just more strongly associated. So sorry for this really busy table. We'll go through most of them with the other questions as well. I just thought it'd be useful for you to have a bit of a summary, because you can get really lost in this topic. But essentially, hemolytic anemia just means destruction of red blood cells, and so your hemoglobin is low, so you have anemia. But inherited causes will generally affect the membrane of your red cells or your metabolic machinery or your hemoglobin itself. So hereditary spherocytosis and elliptocytosis affect the cytoskeleton of your red cells, so they don't really let it pass through capillary beds, so they deform. They're autosomal dominant in their inheritance, and they lead to you being anemic. G6PD deficiency, we'll talk about that a bit later on, but that predisposes your red cells to oxidative damage. Hemoglobin molecule deformities, so things like sickle cell and thalassemias, they'll make you you'll destroy your red blood cells because they're abnormal. And then you have inherited causes, so they can be immune mediated or non-immune mediated, and the immune mediated ones were what this question was about. So symptoms of hemolytic anemia will be things like the classic anemia stuff, so like jaundice, shortness of breath, palpitations, some chest pain, tiredness, but there's some other bits in there as well. So because you're breaking down your red blood cells, the hemoglobin breakdown product is bilirubin, so people get jaundiced, dark urine, pale stool type thing as well. So that's important to kind of distinguish. When you investigate it, you can do a Coombs test. So that's what's quite important in kind of getting the answer to this question, because what it does is it tells you whether the hemolytic anemia has an autoimmune cause or not. So you do the direct Coombs test, which will detect the antibodies on the surface of the patient's red blood cells. So you add a patient's red blood cells to this Coombs reagent, and it will be positive if that patient has autoimmune hemolytic anemia, drug-induced hemolytic anemia, or alloimmune hemolytic anemia. The indirect Coombs test, you use in like prenatal testing when you're doing retesting or cross-matching for blood types. So other things that you'll see on blood tests that would suggest hemolytic anemia: low hemoglobin, obviously, low haptoglobin, you get high reticulocyte counts, so immature red blood cells, because they're trying to make more to make up for it. You get high bilirubin, high LDH, so they're both indicative of increased cell turnover. And you get schistocytes on the blood film, which are like fragments of red blood cells, so that suggests that they're being broken down. Other things that you can do are things like hemoglobin electrophoresis, sickle cell screening is important, urinary hemoglobin, and loads of rogue stuff. But I think these are the main things to focus on. So that's how you investigate it. Autoimmune hemolytic anemia can kind of be in two types, so they call it warm or cold. Warm autoimmune hemolytic anemia is more common, and it's mediated by IgG, and cold autoimmune hemolytic anemia is IgM mediated. So hemolysis in warm occurs in extravascular sites, so that would be like in your spleen, and intravascularly in cold, so it happens in the blood vessel in cold. Essentially in warm, the antibodies will attach themselves to the red blood cell at body temperature and lead to them clumping together, and then the immune system will identify that clump of abnormal red blood cells and destroy them. And then it's the other way around in cold, so that it will happen when your body is colder. So the kind of relationships with different conditions: warm is related to other autoimmune conditions like lupus, which is what this question was about. HIV and EBV is also related to cancers, so non-Hodgkin's lymphoma and CLL, and some certain drugs. While cold autoimmune hemolytic anemia is often related to infection, particularly Mycoplasma pneumoniae, and lymphoma as well. The way you treat it is with supportive transfusions. So if they're really, really anemic, you'll want to replace it. Steroids and other immunosuppressants to stop your immune system attacking your red blood cells. If you get quite like large splenomegaly because of all of the destruction of the HB in your spleen, then you can end up having your spleen taken out. And in cold, you'd be advised to avoid the cold because that would like precipitate a crisis. So these are just some different symptoms that you can get in warm and cold hemolytic anemias. So warm, as I said, you'll get this enlarged spleen. You can also get VTE. I think that risk is kind of quite a complex thing to go into, but essentially when you have this type of hemolytic anemia, you're in a bit of a prothrombotic state, and you can get DVTs and PEs. In the cold autoimmune one, you can get circulatory symptoms, so you can get Raynaud's and kind of really cold hands and feet. Okay, so question 4. This one's kind of looking at what we've already touched on, so G6PD deficiency. So we know it's a type of inherited hemolytic anemia, and it's just asking you about the inheritance pattern of that. Okay, well done. So most of you have been correct. You've gone for X-linked recessive, which is the right answer. So G6PD deficiency is an X-linked recessive hemolytic anemia. X-linked recessive means that the gene that codes for it is on the X chromosome, and you need to have 2 X chromosomes to express it if you're a girl. But obviously, if you're a boy, you only need to have the 1 X chromosome with it on to get the condition. So it's kind of complex to wrap your head around, but G6PD is basically a molecule that has a role in making another molecule called NADPH. And NADPH is important because it scavenges like oxidative metabolites, which can damage our red blood cells. So if we're deficient in G6PD, then our cells are more predisposed to being damaged by these oxidative metabolites. So you get more hemolysis of your red blood cells because you've got less of this NADPH. Does that make sense? So it's more common in African, Asian, and Mediterranean populations. So you're advised to avoid oxidative stressors. So things like broad beans, nitrofurantoin, quinolones, sulfonylureas, they're all oxidative stressors. This is the classic like MCQ where it's like this boy has a meal of fava beans or broad beans and then comes in like a hemolytic crisis. And so this is the condition that he has. So on his blood film, you might see things like Heinz bodies or bite cells, and that's just evidence of the hemolysis. And you can see that there in the picture on the right. So next question. This one's about a boy with sickle cell, and it's asking you about the best treatment for him in the acute phase. And yeah, you've all got the right answer. So the majority of you have gone for A, IV fluids and paracetamol. So that's the correct answer. All these other ones are just trying to trick you. So IV fluids and paracetamol is like supportive management for this boy who's come in with a sickle cell crisis. So he's got dactylitis in his hands. His parents report that he's been unwell. He's had a fever, diarrhea, reduced oil intake. So you can infer from that he's probably a bit dehydrated, and he's got these warm, tender hands. Hydroxyurea reduces kind of the disease-related health complications. It increases your fetal hemoglobin, but it doesn't treat the acute phase. A splenectomy, so this guy's got no sign of splenic sequestration or infarction, so there's no indication to remove his spleen right now. Penicillin V is an antibiotic that you give as prophylaxis against encapsulated organisms in sickle cell, and it doesn't sound like he's got an infection. And also giving him prophylactic antibiotics isn't going to treat his acute problem. And then a stem cell transplant. So it's the only cure for sickle cell that we have, but it wouldn't be appropriate as an acute treatment for this. So sickle cell, just going back to the basic, like what does hemoglobin look like and how is it made. So it's got 2 alpha and 2 beta chains, and the chains are coded for by genes. The genes are on chromosome 11 and chromosome 16. So in sickle cell anemia, you've got an autosomal recessive mutation on chromosome 11. And I just always remember from medical school that it's in like first and second year, they tell you that glutamic acid was replaced with valine on chromosome 11. And it leads to a functionally impaired beta globin chain. So you, instead of getting the normal adult hemoglobin molecule, you get sickled hemoglobin molecule. So it's just less functionally good. It kind of deforms when it's deoxygenated. And so that means that your immune system will identify it and break it down, which makes you anemic. And it can also mean that it gets stuck in your smaller vessels and occludes them. So you end up having these vaso-occlusive crises. So it manifests in lots of different ways. It can manifest as avascular necrosis of your hips and shoulders, can manifest as sepsis because your spleen is like, it's not, you're hyposplenic, so you're not as good at fighting off encapsulated bacteria. So that's things like strep pneumoniae, Haemophilus influenza, Neisseria meningitidis, and Salmonella. One of the other random facts that you might want to remember for if the MCQ ever comes up is that people with sickle cell anemia are quite at risk of Salmonella osteomyelitis. So if they come in with osteomyelitis and it's like, which bug is likely to have caused this? It's Salmonella. They also get aplastic crises, hepatosplenomegaly, and CKD. The vaso-occlusive phenomena are what we're testing in this question. So this guy's coming with dactylitis. You can also get priapism, so that's like a sustained erection in the absence of sexual arousal, stroke, acute chest syndrome, renal infarction, bony infarction, and sequestration. So that's like blocking of the blood being able to leave the spleen. And they're obviously acutely painful, and they're all precipitated by like physiological stress on the body. So if they're hypoxic, if they're dehydrated, things like that. And that's why the management of these acute crises is generally supportive. So you treat the precipitant. So you give pain relief, you give hydration, you give oxygen, you can even intubate people if you really need to. And then you do your classic buffalo if they were a septic patient. If they're really anemic and they're symptomatic with their anemia, you can give them supportive transfusions. And if they've got priapism, you can aspirate the blood from the penis in emergency situations. So in terms of long-term preventative management, you can give prophylactic penicillin V to prevent those encapsulated organisms causing infection. It's really important that these patients get regular immunizations, especially their pneumococcal vaccine. Hydroxyurea or hydroxycarbamide, people might be eligible for that if they've got recurrent painful episodes, and it will just increase your circulating fetal hemoglobin, which is better than the sickled one. You can treat with steroids and a splenectomy, and then, as I said, a stem cell transplant is the only thing that would cure it. So question 6. So this one's about a young baby. Family have recently moved to the UK from Egypt. The baby's weight's below the 2nd centile for his age, so got a baby with failure to thrive, and he's pale. He's got a distended abdomen and a large head with frontal bossing and a microcytic anemia. So what's the most likely diagnosis? Yeah, you've all got it. So the majority of you have gone for D, beta thalassemia major. Well done. So the key parts of this question are that the baby's like failing to thrive. Also the epidemiology comes in a bit here. So thalassemia is more common in Mediterranean and Northern African countries. He's pale, he's anemic, and he's got some bony deformities in his head. So CLL would be extremely unlikely in this age group, and we've got no history of lymphadenopathy, and it wouldn't cause those bony abnormalities. AML tends to affect adults. It's ALL that affects children, and it leads to like a pancytopenia. There's no suggestion of that in this question. There's no sign of him having low platelets, so there's no bleeding or bruising, and there's no lymphadenopathy. Hydrocephalus would give like young babies a large enlarged head, but it wouldn't account for anemia, bony change in the distended abdomen. Beta thalassemia is the right answer, and haemophilia A, so that's a bleeding disorder, and there's no evidence that this baby's had bleeding. So thalassemia is an autosomal recessive condition that leads to abnormal and low quantities of hemoglobin. You can get alpha thalassemia or beta thalassemia, but beta is more common. and the defect in the chain that codes for them. Major means that you have a total absence of the chain, so there's no functional hemoglobin really. Intermediate, so is mild, so you'd have a lesser deficiency, and then trait, beta thalassemia trait, is generally asymptomatic, but it does confer immunity, I think, against malaria, so it's got like a survival advantage in certain countries, so that's why the trait gets passed on and it still exists as a condition. So it presents classically with a microcytic anemia, delayed growth in puberty, splenomegaly because you've got lots of hemolysis, and jaundice because you've got lots of hemolysis. You get bone marrow expansion, which makes you more susceptible to fractures. You get like a pronounced forehead and pronounced cheekbones, which is what's described as frontal bossing, and pronounced malar eminences. They're at increased risk of infection, and when you treat these patients with repeated transfusions, they can get iron overload. So that's really, you need to be really careful to watch out for that when you're giving lots of transfusions to people, because that can cause cirrhosis and infertility and heart failure. And it can also damage your endocrine system as well. So yeah, as I've said, the management is essentially with transfusions and iron monitoring or chelation. So you can kind of gather iron with a drug called desferrioxamine and take it out of the system. And I think, yeah, again, you could cure it with a stem cell transplant. So question 7. This is about a lady who's on the ward, recently just started having a blood transfusion, and she now feels breathless and has an itchy rash. She's got an elevated respirate, normal sats, she's a bit tacky, she's hemodynamically stable though, and she's got a slight low-grade fever. So there's some split here between A and B. So the correct, I'll leave it there, but the correct answer to this is B. So I'll explain why. So for I think what we've got confused between in the question is anaphylaxis and a mild allergic reaction to a transfusion. So anaphylaxis would be like airway compromise, hemodynamic instability, be unlikely that she'd be able to talk to you in the immediate phase. And so these observations don't really suggest to me anaphylaxis. That wouldn't really account for the low-grade fever, and her blood pressure would probably be much, much lower. Her sats would be falling. I might have mentioned in the question something about stridor or angioedema, stuff like that. But she's got a little bit of an itchy rash. She's a little bit breathless, but generally she's quite stable. So the answer is that it's a mild allergic reaction to her transfusion. C, what we're getting at there is kind of like an infection from the blood. Low-grade fevers can occur with an allergic reaction or febrile non-hemolytic transfusion reactions. So there's not really any indication at the moment for her to have empirical IV antibiotics. There's no signs of her having circulatory overload, so we don't really need to stop the infusion, request a chest x-ray and start frusemide, because that would be for TACO. We'll go into that in a second. And it is important that we treat this lady, because it's unpleasant to be sitting there feeling breathless and itchy, and you don't want it to develop into a more serious allergic reaction, so you want to stop the infusion and monitor the patient. So transfusion reactions, you can split them into early, within 24 hours, and late. So early, you can have acute hemolytic reactions, which is where the red blood cells react with the antibodies that are in the donors. So like as the patient's red blood cells will react against the antigens on the donor red blood cells and lead to them being broken down. Generally, those patients present quite agitated, rapid onset fever, hypotension, shock. You can get abdominal and chest pain. It's kind of more severe and more acute. A mild, you can also get allergic reactions that range from mild allergy to anaphylaxis. They're generally more common allergic reactions if you're transfusing plasma-rich products, so things like FFP and platelets, because there's more proteins in them to react to. And so you can get itchy, you can get like little rashes and wheals, short of breath, and low-grade fevers with that. And if it was a mild reaction, you just give all antihistamine and steroids. Obviously, it was anaphylaxis, you proceed to IM adrenaline, and you'd put out an arrest call. Febrile non-hemolytic transfusion reactions are when the recipient's antibodies react with the white cell antigens or white cell fragments in the blood product. And you just get kind of fever, chills, muscle pains, nausea, itchy, and it's the same management as for a mild allergy. So you give a steroid, you give paracetamol and you give an antihistamine. TACO, so that's transfusion-related circulatory overload. So you'd get features of acute pulmonary edema quite soon on. So people would have things like raised JVP, maybe a third or fourth heart sound, crackles in the lungs. So you'd want to be offloading them. People are more at risk of circulatory overload if they're kind of small, frail, elderly patients with heart failure or renal impairment. What you want to make sure with TACO is that the patient's not having an MI, so make sure you always ask for an ECG. TRALI, so that's transfusion-related acute lung injury, usually within 2 hours of a transfusion, but it can be up to 6 hours after. Those patients will present with hypoxia and bilateral pulmonary infiltrates in the absence of like a heart failure or an overload as a cause. So that's because the donor antibodies are reacting with the recipient's white cell antigens and the lung lining, so it leads to kind of an immune reaction. So they'll be short of breath, hypoxic, fevers, rigors, they can be hypotensive. So then you'd want to stop the transfusion and give them respiratory support them hemodynamically. Some of these patients might end up going to ITU. The main thing about TRALI is that it's a diagnosis of exclusion, so you need to make sure you rule out things like TACO first before you go to that. And then the late things are things like infections, like bloodborne virus infections, graft versus host. You can get post-transfusion purpura because you can get kind of profound thrombocytopenia after having a transfusion. So these patients can present with like bruising or actually mild to severe bleeding. And then you can get iron overload, as I've said, with thalassemias when they're having recurrent transfusions. Cool. Question 8. So this question is about a young boy with a painful, swollen, bruised knee following minor trauma. So he's had an X-ray and an ultrasound, and we think he's got blood in his joint. His mother says that he's always had easy bruising. And after he was born, his umbilical stump bled for a long time. And we think he's got haemophilia A, so which clotting factor is deficient? Yeah, most of you have gone for the right answer, so B. So haemophilia A is a deficiency of factor 8. Well done. So you can get haemophilia A and B. They're both X-linked recessive conditions. The way that I remember it is factor A is 8, and it sounds like 8. Factor B is, haemophilia B is factor 9, and that's also called Christmas disease. So these can be X-linked recessive inheritance, or they can be, in 30% of people, they can be de novo mutations. They both present similarly to each other, and carrier females are rarely symptomatic. So they present with easy bruising, nosebleeds, heavy periods, hematomas, bleeding into joints, bleeding after surgery, blood in the wee, bleeding in the brain, or cord bleeding in babies. And the management's generally a multidisciplinary team management, so you can manage it with recombinant factor 8 and factor 9, prophylactically, or if they're bleeding. And you can give desmopressin as well, which will prolong the lifespan of von Willebrand factor. You can give tranexamic acid in major bleeds. You'd avoid IM injections, and just educating patients on things to avoid is also useful in haemophilia. Cool, so question 9. This one's about a pregnant lady with a DVT. What's the most appropriate treatment option for her? So is it a DOAC? Is it low molecular weight heparin? Is it warfarin? Or is it dual antiplatelets? Cool, well done. So most of you have gone for C, which is the low molecular weight heparin, enoxaparin. That's the right answer. For this one, I've just combined 2 questions in one. So if you guys answer question 10 now as well. So a 30-year-old man presents with a TIA. symptoms resolved are 3 hours TIA. The patient has no risk factors for VTE, no family history of VTE. Which of the following thrombophilias is acquired? So acquired as in not inherited and developed throughout your lifetime. Okay, so there's a bit more confusion with this one. It's quite a hard question, to be fair, so sorry. The correct answer is actually D. You guys have gone for a mixture of A, C, D, and E. People weren't keen on B. I think you guys spotted that von Willebrand disease makes you bleed, it doesn't make you clot. So the rest are all thrombophilias, but factor V Leiden, protein C deficiency, and antithrombin deficiency are all inherited, and antiphospholipid is acquired. Okay, so a thrombophilia is a disorder of hemostasis that predisposes someone to clotting. You'd suspect it when people are having episodes of spontaneous, recurrent, or severe VTE, possibly at a young age. So inherited ones like factor V Leiden, that's basically the most common inherited thrombophilia. Factor V Leiden is activated protein C resistance. So clotting factor V obviously works to aid clotting, and protein C will inactivate factor V, so stop the clotting. Factor V is inactivated more slowly in this condition because the factor V is resistant to protein C, so it carries on kind of helping the clotting for longer. It can increase your risk of clotting by like 10 times if you have the homozygous form, so it is a significant thrombophilia. And then protein C and S deficiency, antithrombin deficiency, prothrombin gene mutations, they're all inherited thrombophilias. And then acquired ones are things like antiphospholipid syndrome. So antiphospholipid syndrome is where you have autoantibodies in your blood, which essentially just makes your blood more coagulable. So those autoantibodies will bind to proteins in your phospholipid membrane and prevent the breakdown of clots, etc. It will predispose you to VTE and adverse pregnancy events. So women with recurrent miscarriages are often investigated for thrombophilia. Antiphospholipid syndrome also makes you more at risk of having arterial clots as well. So things like MIs is significant in antiphospholipid syndrome. The other kinds of acquired ones are just having cancer, heart failure, being on the pill, stuff like that. So in terms of treating a VTE when it happens, this table is like from the NICE guidelines. I think it's really useful for your revision just to have it. So the question about the pregnant lady, should she be on a DOAC or a warfarin or a low molecular weight heparin? Warfarin's teratogenic in pregnancy, and they don't generally use DOACs in pregnancy either. So you normally treat thrombophilias in pregnancy with a low molecular weight heparin. There are other contraindications to different things as well. So if the patient has no kidney impairment, no antiphospholipid syndrome, then you'd give them a DOAC like apixaban or rivaroxaban. If they've got renal impairment and their creatinine clearance is less than 15, then you would avoid a DOAC as well, and you'd go for low molecular weight heparin. If they've got active cancer, you can still give a DOAC. If they've got antiphospholipid syndrome or things like prosthetic heart valves, generally you also go for warfarin, but you bridge them with low molecular weight heparin in the interim. I think this is a really good table though, so definitely fill in the feedback and get the slides. Cool. Question 11. This question's all about the coagulation screen bloods. I don't know, I always found them so confusing. I think it's just the clotting cascade that throws people off, but this patient's 64, treated for severe sepsis, has now got a petechial rash and is oozing blood from his central line. So we think you've got DIC. What kind of blood results on his clotting screen would you expect to see? Well done. So most of you have gone for C, which is the right answer. So he would have a prolonged PT and APTT, a positive D-dimer, low fibrinogen, and low platelets. So if we just go through why, so a shortened PT and APTT, so that's like answers A and D, that would indicate hypercoagulability. So while you do form clots in DIC, you consume all your clotting factors, so you have a prolonged PT and APTT. So A and D are incorrect. And then so that leaves B, C, or E. Is it a positive or a negative D dimer essentially? High fibrin degradation products will be seen in DIC because you've got more clots being formed, so more are being broken down. So you'll have positive D dimers. So that leaves C and E. And the difference between C and E was low fibrinogen, low platelets, or is it high fibrinogen, high platelets? So if you're consuming all your platelets and all your fibrinogen trying to make clots, then they're going to be low. So the answer is C. This is your clotting cascade. It's a bit of a throwback. It's quite grim. You don't need to memorize it, but it's important to have an awareness of the different elements of it. So under normal hemostasis, your procoagulation and your anticoagulation are going to be in balance. So you've got fibrin generation through the clotting cascade, which means that you are clotting, and you've got fibrinolysis, which is clot breakdown. So that's when plasminogen is converted to plasmin, which then breaks down the fibrin clot. So when you get damage to a vessel, tissue factors then exposed to the blood, which recruits platelets to form a plug, and then that triggers the clotting cascade through factor 7. And so you reinforce your platelet plug by forming this hard fibrin mesh over the top of it. But you can't continuously form that fibrin mesh because then the clot would get bigger and bigger and bigger and bigger and clot off the whole vessel. So you have to have fibrinolysis going on at the same time to break down the clot in healthy hemostasis. So you're clotting, but you're also breaking it down at the same time. Cool. So the two main ones are part of the question that get confusing is the prothrombin time and the activated partial thromboplastin time. So your PT is the time that it takes for your blood to clot via the extrinsic pathway. So a good way to remember that, I think it's from 0 to finals, is that you play tennis outside. So your PT is measuring your extrinsic pathway. So because if you look back at this slide, there's not very many clotting factors in your extrinsic pathway, there's literally just factor 7. What you can use PT as a surrogate for is really a measure of your overall clotting synthesis or function. So it'll be affected by things like liver disease, DIC, vitamin K deficiency, and probably all anticoagulants. And then your APTT is the time it takes for your blood to clot via your intrinsic pathway. So you play table tennis inside, so your PTT is intrinsic pathway. So the intrinsic pathway has factor 12, factor 11, factor 9, factor 10, and then all the other ones. So it's a measure of your overall clotting synthesis and your levels of those factors as well. So it will also be affected by things like haemophilia A and B, von Willebrand's, antiphospholipid syndrome as well. DIC is quite a complicated thing to get your head around as well, but essentially it's an acquired syndrome where you're activating your coagulation pathways, so you're developing lots of intravascular thrombi throughout your body, but you're also depleting your platelets and your clotting factors, so you can't really make new clots, so then you bleed elsewhere. And yeah, imbalance between coagulation and fibrinolysis. So it can occur in things like trauma, severe burns and sepsis, malignancy, obstetrics disorders. So in preeclampsia, you can get that HELP syndrome, and liver failure. And it will present with kind of large bruises and bleeding. So they can be GI bleeds, ENT bleeds, lung, brain and kidney bleeds, confusion and fevers, renal failure, ARDS, and then those skin signs, so petechiae, purpura and skin necrosis. And the management is really supportive. There's nothing we can do once started to stop it, other than transfuse platelets, transfuse clotting factors with FFP. We can support patients' ventilatory system and hemodynamic system in ITU, but obviously prognostically it's not a great thing to have. Cool. Question 12. So I'll just get the poll for that. Sorry, my thing's disappeared. Oh, I've shown you the answer anyway. We won't bother with the poll for question 12. So a 10-year-old girl is brought to A&E by her mother. She's very concerned she might have meningitis. She's got a 1-week history of a viral illness, and now she's got a petechial rash and some bruising on her legs. The patient's bloods and OBS are fine, apart from the fact that she's got a platelet count of 25, which is really, really low. So which of the following options represents most appropriate treatment for the patient's condition? Is it a platelet transfusion, prednisolone, tranexamic acid, IV immunoglobulins? Well, it's no treatment required. What a surprise. So generally, we don't transfuse platelets unless the patient's actively bleeding or about to have a procedure, or they're septic, or their platelets are like less than 10. So you tolerate a really low platelet count before you transfuse someone. If you transfuse someone with this condition, so does anyone know what this patient likely has? Do you want to put it in the chat if you think you know what it is? Oh, showing all the slides. ITP, yeah, well done. So immune thrombocytopenic purpura. So if a patient has ITP, they have antibodies that are destroying their platelets from having this viral illness, and it's self-limiting and it will last a couple of weeks and then it will go away. But if you transfuse someone platelets in the meantime, their antibodies are just going to destroy those platelets as well. So there's no point really giving her a transfusion. Prednisolone, you'd consider giving prednisolone if they were actively bleeding or their platelets were less than 10. Tranexamic acid you use if they were having a major bleed, but there's no sign that she's actively bleeding. IV immunoglobulins are the same, so if they were actively bleeding, you could try that. So thrombocytopenia is classified as platelets less than 150. It can be quite severe. So like in this girl, having platelets of 25 is quite severe. And so ITP or thrombotic thrombocytopenic purpura, you can get quite severe low platelets in that as well. Same with DIC and hematological cancers. Other things that can drop your platelets are having heparin, certain drugs, alcohol, liver disease, hypersplenism, that HELP syndrome, and viral infections. I've made this table isn't like the law, but it's a good rule of thumb generally for when you transfuse platelets. So if the patient's not got any bleeding and is otherwise well and doesn't have any planned procedures, you tolerate platelets of like above 10 before you thought, oh, I do really want to transfuse them now. If the patient has clinically significant bleeding, then you would transfuse them to get their platelets above 30 to 50. If the bleeding was at a critical site, i.e. it was in your brain or your central nervous system, then you'd aim for over 100. If they were septic, you'd aim for over 20. And if before an invasive procedure, you'd aim for over 50 as well. Some people are just asking about the difference between ITP and TTP. So ITP, we'll go on to it just on this slide. So ITP is an idiopathic thrombocytopenic purpura. So it's like a type 2 hypersensitivity reaction where your antibodies destroy your platelets, and that's not the case in TTP. ITP generally presents in children less than 10 with a history of recent viral illness. TTP generally presents in adults who are previously healthy, who present with like a mental state change, fever, and things like that. Whereas ITP, the child's generally well, has had a recent cough, cold, and then they've got some bleeding or bruising or a petechial rash. The way you manage it, you would only step in really if they've got active bleeding or platelets less than 10. And in that case, you'd give prednisolone, IVIG. Supported blood transfusions or platelet transfusions would only be a temporary fix. And you'd advise them in the meantime to avoid contact sports, IM injections, and drugs like NSAIDs. Cool. Question 13. So this is an 82-year-old man who's presented with malaise, night sweats, and fevers. Which one would support a diagnosis of CLL? Okay, so there's a split between B and C. So lymphopenia, i.e. low lymphocytes, or lymphadenopathy. So the answer is lymphadenopathy. The hematological cancers are really hard and like to split them up in your head. So I've tried in the way that I've written these slides to like make them into a table, because I think it's useful to see it all on one slide rather than going through them all individually and then they all get confused in your brain. But I apologize that the slides are a bit noisy. So going through these answers, so chronic lymphocytic leukemia, A, hypercalcemia. You don't get hypercalcemia in CLL, you get hypercalcemia in myeloma. B, lymphopenia. You actually get lymphocytosis in CLL, so you get more lymphocytes rather than less. Lymphadenopathy is really classical of CLL. Renal impairment, that's another myeloma one. And then thrombocytosis, actually CLL causes thrombocytopenia. So Leukemias are malignancies that arise from a cell line in your bone marrow. So you get unregulated production of some cell lines and suppression of others, which leads to a pancytopenia. So you've probably all seen this before. This is like hematopoiesis, that classic. So you've got your multipotent stem cell that can become anything, and then it splits into myeloid lines and lymphoid lines. So your AML and your CML are all cancers of these cells, and your CLL and your ALL are all cancers of these cells. So if we go into the key features of each one, this is what I'm trying to do to stop you just being overwhelmed all at once, to just put big pink squares on it, but it's a bit jarring. So ALL is acute lymphocytic leukemia, and that will present in patients who are less than 5 or over 45. So it's the most common cancer in children aged 0 to 4. And it's uncontrolled proliferation of immature lymphoblasts. And the majority of those lymphoblasts are B cell lineage. So just going back to here, so it's an ALL, so it's on the right hand, the right hand side of this diagram, and the majority of the cancers arise in B lymphocytes, B cell lineage. And it leads to bone marrow failure and tissue infiltration. So when you get this like rapid proliferation of B cell blasts, then you suppress your production of your hemoglobin, you suppress your production of your white cells, and you suppress your production of your platelets. So you get anemia, neutropenia, and thrombocytopenia. So then the symptoms that arise from that are fairly self-explanatory. So you'll get the classic symptoms of anemia. So you'll be fatigued, short of breath, exertional chest pain. The classic symptoms of neutropenia, so you'll be more predisposed to infection. And the classic symptoms of thrombocytopenia, so bleeding and bruising. The tissue infiltration side of things is different. So you get so many of these cells that they just block up your bone marrow. So you get bone pain, they block up your other kind of lymphoid sites. So your lymph nodes will get bigger, get a bigger spleen, and you can even get CNS involvement in it as well. So that's ALL. And then AML is the other acute leukemia, but this one presents in adults. So it's uncontrolled proliferation of the other side of the diagram, so the myeloid lines. So you get lots and lots of immature myeloblasts. It's quite similar features to ALL, but obviously it doesn't present in children, it presents in adults. And it can result, so if patients have things like polycythemia vera, myelofibrosis, or other myeloproliferative disorders, they might be more at risk of getting things like AML. So that essentially leads to bone marrow failure, so the classic anemia, neutropenia, thrombocytopenia. The tissue infiltration is a less prominent feature in AML than it is in ALL. CLL is the most common leukemia in adults overall, and it generally presents in patients over 55. It's an expansion of more well-differentiated B cells, and it's a slow and indolent course, so it's highly treatable, but you can't cure it. Lots of older adults will live with CLL and die of something else first. They're mostly asymptomatic, and they might be picked up on routine bloods with lymphocytosis, so high lymphocytes, anemia, and thrombocytopenia. They also classically have lymphadenopathy. CLL is also associated with warm autoimmune hemolytic anemia, and something called Richter's transformation, which is when CLL can spontaneously transform to a high-grade non-Hodgkin's lymphoma. And then the last one is chronic myeloid leukemia. So that's an expansion of abnormal granulocytes, so things like your neutrophils and stuff like that. More than 95% of them are associated with a Philadelphia translocation, so that's the chromosome 9 and 22, forming the BCR-ABL fusion gene. And that gene has more tyrosine kinase activity, which is what causes the problems with CML. CML is a cancer that classically has 3 phases. So there has a chronic phase in which 90% of people are diagnosed, and then an accelerated phase, and some people can go on to have a blast phase, which is where it will convert to like an AML or an ALL type picture. 50% of them are asymptomatic and picked up on a full blood count. And they also have symptoms of like a hypermetabolism, so those B symptoms like weight loss and night sweats. They can get massive splenomegaly, high platelets, and again, the tissue infiltration is less common in CML. So the key tests that you want to do for these leukemias are obviously blood. So you want to do a full blood count, a blood film, because quite often they have classical pictures on a blood film, an LDH, which is the marker of cell turnover, and a clotting. You could also do a chest x-ray, an LP to look for CNS involvement, a lymph node biopsy if they've presented with a massive lymph node, a bone marrow biopsy for phenotyping the cancer and cytogenetics, but you'd only do that if you thought it was worthwhile. So if someone was presenting with CLL who was a really elderly, frail patient, and you're pretty confident from the bloods that they have CLL, and you're probably not going to give them chemo, there's no point putting them through a bone marrow biopsy. Then you might also want to do a staging CT, MRI, PET scan. So going back to this horrible table again, in terms of key findings on the blood film and the management of each one of them. So ALL, you get big abnormal blast cells on your blood film and you get a positive TDT stain. Managing that, so you treat the infections that they might get from the neutropenia, you'd give them transfusions for their anemia. The chemo that you give for ALL, you generally give it in like long blocks because your aim is to induce and maintain remission. It's important to remember that ALL can be like secreted away in sanctuary sites, and so those are places where the chemo finds it hard to get to, and that can be your brain, your spinal cord, and your testicles. So you can consider radiotherapy of those areas, but generally the chemo can be like 3 years long in boys, 2 years long in girls. You'd also go for more intensive chemo drugs if they presented with features with poor prognosis. So if they got ALL and they were more than 10 years old, that's a poor prognostic sign. If they've got T-cell disease or white cell counts more than 50, then you'd go for like more intensive chemo regimens. And you can give stem cell transplants. Generally, these young patients that get ALL are more fit and healthy, so they'd be more suitable to have a stem cell transplant. The other ones could theoretically be treated with a stem cell transplant, like the CML and the CLL, but your patient group that get those things are generally less well, so wouldn't really tolerate one. AML, so the key features on your blood film are things like hour rods. That's the classical AML. So there's a picture of them there. And they have positive MPO staining, so that kind of differentiates ALL and AML. Managing it, so the chemotherapy for AML is generally shorter and a bit more intensive. It's highly myelosuppressive, so it's obviously going to cause a lot of side effects, and the specific treatment will depend on the specific mutation that you have. And then again, plus minus stem cell transplant. CLL, so the blood film, you'll see things like smudge cells, they're those ones with the kind of like the little trails. And the ones that look, kind of like they're smeared across the film. The management of CLL is generally a watch and wait approach. So you do bloods every 3 to 12 months to monitor it, and you'd consider starting treatment if they were getting pancytopenic or symptomatic with the big lymph nodes, or getting weight loss, night sweats, fevers, things like that. And then CML, the film will show immature and mature myelocytes and blasts. And the management for CML is tyrosine kinase inhibitors. So they've kind of transformed the management of CML. And that's things like imatinib. And then if you go into blast transformation, then you'll treat it as like AML or ALL with intensive chemotherapy. This is cool pictures of each one of them. That is quite nice in terms of like trying to differentiate them in your head. So if you fill in the feedback and get the slides, you can look at these like med comic pictures that I think are quite good in separating them in your head. Cool. So question 14. We're nearly there, guys. Well done for staying with me this far. So this question is about a man with HIV presenting with painless cervical lymphadenopathy, weight loss, gross hepatosplenomegaly. They've referred to haematology, they've done a biopsy, and this is what the biopsy looks like. What are the cells? You've all smashed it. You've all put Reed-Sternberg cells because this man has lymphoma. So just differentiating them in your head again is what I think is important with haematology. So leukemias are cancers of a cell line in your bone marrow. So immature blast cells will arise in the bone marrow, and it's uncontrolled proliferation of that. A lymphoma is a cancer of lymphoid tissue. So mature lymphocytes will arise in sites outside of the bone marrow, so like your lymph nodes. And lymphomas can be high or low grade, and they can be cancers of B or T lymphocytes. So we have Hodgkin's and non-Hodgkin's lymphoma. And Hodgkin's lymphoma is about 20% of the lymphomas that we get every year, and then the rest of them are all non-Hodgkin's. So non-Hodgkin's lymphoma is actually just a group of lots of lymphoma types that don't have Reed-Sternberg cells. So Hodgkin's lymphoma generally has a bit of a better prognosis. It presents in older children, teenagers, and young adults, people with a family history. It will have those Reed Sternberg cells, which are the giant multinucleated cells with the bilobe nucleus. So you can see it's got 2 nuclei there. Diffuse large B-cell lymphoma, follicular lymphoma, Burkitt's lymphoma, lymphoblastic lymphomas, MALT, and anaplastic lymphomas. They're all types of non-Hodgkin's. They present in generally people who are over 55 and can be associated with HIV, EBV, H. pylori, hepatitis, and things like that. Generally, they actually present quite similarly. It's hard to differentiate the two. And the main way that you'll be able to differentiate the two is by doing a lymph node biopsy and looking for those Reed Sternberg cells. So Hodgkin's lymphoma can present quite insidiously. 70% of patients will have lymphadenopathy. The classical one is like cervical lymphadenopathy that is painful when you drink alcohol. If you have it in your mediastinum, you're at risk of getting superior vena cava obstruction. And you'll also get those B symptoms, hepatosplenomegaly, malaise. The non-Hodgkin's ones, they can either be high-grade aggressive or low-grade indolent. And there's just like a couple of features that you can remember for each one. So Burkitt's, it's classically like jaw lymphadenopathy. Diffuse large B cell is like a rapidly growing mass in your neck or your abdomen or your mediastinum. The B symptoms are less so in non-Hodgkin's than they are in Hodgkin's. And you can also get marrow infiltration in non-Hodgkin's, so you get all the pancytopenias. They're both managed with chemotherapy, radiotherapy, and potentially surgery to debulk the tumour. And the staging system that you want to remember is Ann Arbor, and that's what the picture in the top right is about. So stage 1 would be like a single lymph node group. Stage 2 is 2 lymph node groups, but on the same side of the diaphragm. Stage 3 is 2 or more lymph node groups above and below. And then stage 4 is widespread multiple organ failure with lymph node involvement. So that's another one of those nice cartoons about Hodgkin's lymphoma. And the Reed Sternberg cells, people say they look like an owl. Oh, on to the last question. So this one is about a 71-year-old lady who's come in with confusion. She hasn't opened her bowels in 10 days, so she's quite constipated and she's got pain in her legs. Looking at her blood test, she's got a normocytic anemia. She's got thrombocytopenia, neutropenia. She's got a bit of what looks like an AKI and a high calcium. So given the likely diagnosis, what is the most appropriate test to request to assess for end organ damage? So this is quite a hard question. And it's kind of reflected in your answers. So there's a bit of a spread across all of them. Does anyone know what diagnosis we're trying to get at with that history of confusion, constipation, leg pain, high calcium, AKI, pancytopenia, multiple myeloma? Yeah, really well done. So in terms of end organ damage, we've already got U's and E's, so we know that she's got some kidney damage going on. The other thing that NICE recommend to assess for end organ damage in myeloma is a whole body MRI. So bone marrow biopsy, that's going to confirm the diagnosis of myeloma, but it's not going to confirm any end organ damage. Serum free light chains is also going to support your diagnosis of myeloma, but it's not going to confirm any end organ damage. And then the 3 whole body CT, skeletal survey, or whole body MRI, that's where NICE recommends MRI first. If we can't do an MRI, then do a CT. And if we can't do a CT, then do a skeletal survey. And what we're looking for in those tests is evidence of bone lesions, so like lytic bone lesions. So going back to just distinguishing the 3 again, because they can all just blur into one. Leukemias are malignancies of a cell line in your bone marrow, like immature blast cells proliferating in your bone marrow. A lymphoma is a malignancy of your lymphoid tissue, so mature lymphocytes arising in sites outside the marrow. And then myeloma is a plasma cell malignancy. So you can get diffuse marrow infiltration, you get bone destruction and marrow failure, and you get oversecretion of immunoglobulins, which is going to damage your organs like your kidneys. So I like to split it into blood, bone, kidney, and other in terms of the symptoms of myeloma. It's an incurable condition, but it is treatable. Risk factors for it are things like age, being Afro-Caribbean, and having the RAS oncogene mutation. People remember the symptoms classically with the acronym CRAB, so high calcium, renal impairment, anemia, and bony lesions. In your blood, you'll be anemic, neutropenic, and thrombocytopenic because of your marrow suppression. In your bone, you'll get lytic lesions. They're commonly in your skull, spine, and long bones. You can get pathological fractures because of those, and bony pain like Our Lady did. And the reason you get bone disease in myeloma is because of increased osteoclast activity and suppressed osteoblast activity. So your osteoclasts absorb your bone and your osteoblasts deposit your bone. So we're basically just breaking down bone more. And then you'll get you get hypercalcemia because of that bone breakdown. So then you get all the symptoms associated with hypercalcemia. So the renal involvement is because your immunoglobulin chains deposit themselves in your loop of Henle and can cause you to get an AKI. It's also because hypercalcemia will impair your renal function. Generally, they might be dehydrated, and the medications that you use to treat myeloma can also impair your kidney. So things like bisphosphonates. And then the other symptoms that you get are like hyperviscosity syndrome. So your plasma viscosity, or like the thickness of your blood, increases when there's more proteins in your blood. So if you're making lots and lots and lots of immunoglobulins, then you're going to have more protein in your blood. It's thicker and kind of increases the inflammation in your body. Raised plasma viscosity can mean that you get easy bruising, easy bleeding, reduced or loss of sight because you get vascular disease in your eye. And you can get things like heart failure as well. And then this bony involvement can lead to spinal cord compression. You can get plasmacytomas, so like big tumours of plasma cells, paresthesia, fevers, hepatosplenomegaly, and lymphadenopathy as well. Investigating myeloma. So the blood tests will classically be a normocytic, normochromic anemia. If you've got healing fractures, you might have a high ALP on your LFTs. You get an elevated calcium, and you get rouleau formation on a blood film, and they're like stacks of red blood cells. There's special investigations for myeloma you can remember with the acronym BLIP. I think that's from 0 to finals as well. So urine electrophoresis will reveal Bence-Jones proteins, and they're like monoclonal light chains in your urine. A serum-free light chain assay, serum immunoglobulins, so just in your blood, and serum protein electrophoresis. Protein electrophoresis kind of will only detect an intact antibody, and actually in myeloma, 20% of myelomas or something secrete light chains, so fragments of immunoglobulins. So you need to do urine electrophoresis and serum-free light chains as well to look for those. You can't rule out myeloma with a negative protein electrophoresis. And then if they're fit enough, you might consider doing a bone marrow biopsy. So NICE recommend whole body imaging to assess for bony involvement with an MRI, with a low-dose CT if you can't do an MRI, and with a skeletal survey if the MRI or the CT aren't possible. And then in terms of managing it, so you need to consider patient fitness. Do we need to treat it, or can we just manage their symptoms? And then the aim would be to induce remission with chemotherapy or a stem cell transplant. If we're just going to manage symptoms, then we can manage bony disease with things like bisphosphonates and radiotherapy. You can do prophylactic orthopedic surgery, so you can like give people intramedullary nails into their hips to stabilize the hip before it breaks. You can give cement augmentation as well of different bones as well. And then you're going to treat the AKI with fluids and encouraging oral intake. And then if they're anemic, you can treat with transfusions or EPO injections. And if they've got an infection, then you'll give them antibiotics or immunoglobulin infusions. That is the end. Well done, everyone, for making it through an hour and a half of haematology. It can be quite a lot of information overload, and you've done really well on the questions. If you guys wouldn't mind filling out the feedback, there's quite a lot of information underneath the slides that I've written to kind of pad it all out. So you will get the slides and the recording if you fill in the feedback form as well. How have we done on questions, Alex? Are there any that you needed to answer?
Yeah, all good questions. There's someone who wanted you to go back through question 14, sort of the other answers and why they weren't right.
That's fine, I'll just skip back. Oh yeah, so we've got Reed-Sternberg cells, so they're the classical Hodgkin lymphoma ones. And then the Howell Jolly body ones, so they're classically seen on blood films associated with hyposplenism. So after you've had a splenectomy, you might see Howell Jolly bodies, but you wouldn't see it in Hodgkin's lymphoma. Acanthocytes, they can also be seen in hyposplenism, but not Hodgkin's lymphoma. Heinz bodies, so they're seen in G6PD deficiency. So do you remember that picture? I can skip back as well, just see, of the bite cells in the Heinz bodies in G6PD deficiency. They look like that. So they look like they've had a bite taken out of them. Yeah, they're Heinz bodies. And then the last one, what was the last one? Was our rods, and they're the ones that are seen in AML. So the ones that look like, oh God, the ones that look like that. Does that answer your question? Hope so. Cool. Well, thanks very much, guys. Have a nice rest of your evening, and hopefully we'll see you next Thursday. Thanks, Alex, for manning the Q&A.